Right, hello everyone. I'm Peter Frampton. I'm an optometrist in Northumberland, and I want to talk to you today about inflammation and allergy. And my title simply says, Understand the First, Understand the Second, and this is important. I've given this talk a few times before, and it goes over quite well, so I thought I'd put it on the website for students to have a look at if they're interested. And I think we're taught in this way. We're taught about inflammation in a bunch of university lectures. We're taught about allergy in another set of university lectures. And we don't tie the two together. And we're taught an awful lot of stuff. We're told all these sorts of cells and all this sort of stuff. And really, I want to simplify it a bit. I'm going to talk to you today about the principles of inflammation. I won't bring up so many particular cells and everything, which just bores everyone rigid anyway. But the principles are the important bit. That's what you need to really understand. So that's what I want to do for you today, and it works really well. I think of it a bit like physics. The principles of physics are great. The maths complicates it. So I want to take out all the complicated bits of allergy and inflammation and just give you the principles, which is important. But I will mention a couple of things which are important to know about because they'll turn up in things that you read. So I do think those things are important to know about, but I'll mention them when I get to them. So first of all, 3 rhetorical questions before we start the ball rolling. First of all, what is a mast cell for? What's the purpose of those things? We're taught about them all the time. We're taught about them really as part of allergy. So what is the point of them? Secondly, in a textbook sense, if you had an allergic reaction to chlorphenicol, would you expect it to be follicular or papillary? And thirdly, if you do not have any allergies to anything at all, so you're not allergic to anything, you don't have any hay fever or anything like that, would you consider yourself hypersensitive to anything at all, yes or no? Now, we'll come back to those questions at the end and see what you think. So first of all, I want to introduce a character called Baron von Berkay, or in my language, Baron von P, because I don't know how to say his name. And he was a German aristocrat, and he described and defined allergy. So when he used the word allergy, it was to denote a host protective thing. It wasn't a bad thing at all. We all think of allergy as a terribly bad thing, but when he coined the term, he used it to mean a host protective mechanism. And similarly, hypersensitivity, he described the status of a mammal after exposure to infectious agent, and therefore the animal was better able to deal with a second exposure. All right, so that's how we think of inflammation anyway. We think of it, we're able to deal with something in a much more effective mechanism. And therefore, it was a good thing. So when Von P talked about hypersensitivity, he meant it in a very, very positive way. But what he's actually describing is not allergy as we see it, but he's actually talking about the acquired immune system. Right? And these two things, the allergic reactions and allergy that we're all going on about with our patients all the time. I mean, I can't remember what the stats is, but something like 40% of the population now is allergic to something. Right? So 40% of your patients that walk in your door are going to be allergic to something. So it's quite important to be able to converse with them and explain things to them. And so understanding the inflammatory response is absolutely critical to you understanding the allergy. But since Von P, we've got these two characters called Gell and Coombs, and they were from 1963, and they categorized allergy and hypersensitivity in this deleterious fashion. Now, these are terms you should know because you will read about them. You'll read about them in Optician magazine. You'll read about them in all sorts of things. And you'll certainly read about them in the clinical management guidelines that are on the college website. They talk about type 1, type 2, type 3, and type 4 allergies. And when they're saying that, they're meaning Gell-Coombe categorization of it. Now, there's 4 types, but actually now there's even more, because remember, this was developed in 1963. But the ones we really deal with is type 1 big time and type 4 a little bit. All right? The other 2 I won't deal with so much in this one. They're often quite serious conditions, and generally they're dealt with in the hospital. Within the community, you will deal with type 1, and that's classified as an immediate IgE-mediated anaphylaxis type thing. So you've got asthma, general atopy, and from the eye point of view, we've got SAC, PAC, VKC, and AKC. If you don't know what that means, seasonal allergic conjunctivitis, perennial allergic conjunctivitis, vernal keratoconjunctivitis, and atopic keratoconjunctivitis. And then type 4 is a delayed response, and that's contact dermatitis. So, nickel-based frames. But what we'll deal with today is topical drug hypersensitivity. So when you've got a hypersensitivity to a drug, it'll be, generally speaking, a type 4. So I think it's important to know these things because they will come up, and I'll show you later in the talk on the clinical management guidelines where they do come up. So now we've got to tie the two things together. In a von P sense, if we're hypersensitive to foreign agents, then we're able to deal with them much more effectively on a second exposure. So that's what he noted. So with the first time we get affected badly. The second time we get infected by the same thing, we respond much better. So this is an essential body defenses. This is inflammation. This is our inflammation. And then allergy in the modern sense is that normal inflammatory process, but when it's triggered inappropriately. Right? So when you're looking at allergy, you are looking at the inflammatory process. And this is the thing, they're just triggered differently. And this is where we're never really taught this. We're taught about one thing, we're taught about the other. They're both flip sides of the same thing. So if we understand the inflammatory processes, then we can truly understand why allergy is working and how we can stop it triggering. So let's talk now about immunology before we get on to allergy. So there are basically three parts of immunology. We talk about barriers. We talk about the innate immune response, and we're all taught these things. And then we're taught the acquired immune response. So we'll go through these. So first of all, barriers. How much time am I going to spend on barriers? That's how much time I'm spending on barriers. If we don't know barriers yet, we've lost the plot, okay? You've got to go back to school. I'm not going to waste time on that. I want to get on the other stuff, the interesting stuff. But we have got barriers, and once they're broken, once they're pierced, that's when the other stuff kicks in. So the second stage is the innate immune response, and we are taught this is the inflammatory response. So when we're taught this, we're taught that it's immediate, that it has no memory, and it's non-specific. And I don't know if you're like me at uni. I wrote all these things down. They were very, very important. I didn't understand them. I just knew I was going to pap them back out at the exam. They're immediate, no memory, and they're non-specific. So what does that actually really mean? The innate immune response, make no bones about this, the innate immune response is the inflammation, right? So if I rub my hand long enough, I'll generate an inflammatory response. And that is the innate immune response. They are completely, the two terms anyway, are completely synonymous, right? So whether it's a stitch in a cornea or a foreign body in your hand, that's the innate immune response or the inflammatory response. Now this is where I'm going to go through it with you. This is where we'll introduce mast cells. Now this graphic took me a long time to do, so I want you all to really enjoy it, right? And normally when I do this, I'm jumping around the place, I'm flinging my arms, I do very much a power wallop type thing, very reminiscent of the 1960s Batman series. Now, you just got to imagine now, in reality, I'm doing this now, but you can't see me, so you're just going to have to imagine that I'm doing this, right? So basically, at the bottom here, we've got the blood vessels. And in our tissue, this is in the open area, in our exposed areas, we've got these things called tissue macrophages. That's the big blighter there. And then we've got these mast cells. Now, they're there all the time. They're primed, and mast cells are pre-primed. They're ready to fling out stuff immediately. They don't have to be geared up for it. And basically these things are in areas that are exposed to the atmosphere where we're likely to get inflammation. Because you don't want something to get inside you, weevil its way all the way to your liver, say, before we start the process. So in comes some bugs. They've actually penetrated our barriers and they're in there and they're ready to go. Now, what happens? Well, if we're lucky, these macrophages, and a macrophage is just something that eats things, right? Hopefully, the macrophage will gobble up those bad guys immediately. End of problem. And quite frankly, this is probably happening to you all the time and you don't even know it. It's all over in a twinkling, right? But if they can't do that, if there's too many of these bugs getting in straight away, what they do is they then start sending out messengers, chemical messengers, and they go down to the blood vessels, but they also go across to mast cells and they trigger the mast cells. So the mast cells are triggered immediately, and remember, as I said before, they're preloaded, they're ready to roll. And bang, they send off these things and they blow out more of the bad guys. And again, hopefully, that's where the problem solves. If it doesn't finish there, then the blood vessels start opening up and we start bringing in other stuff. So this is reinforcements, right? So we need something that's immediate. We need something there at the front line ready to rock and roll as soon as something penetrates. But if we can't get rid of it, then we start calling in the cavalry. And that's when these other things start coming in, which work similarly to these, only instead of being tissue macrophages, they might be plasma-borne, and they're brought in by the blood supply to reinforce the situation. And then equally, they send out more messengers that bring in more things, and the whole thing keeps rolling on. And you know what we've got here? We've got basophils, neutrophils. Neutrophils are another form of phagocytes, so they're eating things, but they're much smaller. They're blood-borne. Eosinophils and so on, and they just generate, and the more this goes on, this just keeps cycling and cycling and cycling. This is why wherever you've got inflammation, your hand or wherever it is might start swelling up until it's destroyed the bad guys. And that is, in a nutshell, that's the inflammatory response. Easy, isn't it? Now, in a type 1 immediate IgE-mediated anaphylaxis, that's actually what you're looking at, right? Nothing more than that. So you're looking at the innate immune system being triggered by something else. And papillae represent this. So this is important because, again, at college we're taught about papillae, we're taught about follicles. We're taught that follicles relate to this. So if you've got a viral conjunctivitis, you'll get follicles. If you get an allergic conjunctivitis, you'll get papillae. We're not taught why. We're not taught to understand it. We're just taught it. But it's basically an innate response which includes mast cells degranulating, and they induce an inflammatory response. And therefore, we think of mast cells being solely to do with allergy. But actually, mast cells are part of the general inflammatory process as they start flinging out all this stuff, the histamine and so on, which causes the itch and so on. So it's always out there. They're popping off every minute of the day, killing something. But it's just if they're triggered inappropriately that we get an allergic reaction. And what you've got to remember as well is that papillae and chemosis are exactly the same thing, right? So again, we're taught to look out for chemosis, which is swelling. We're taught to look out for papillae. Now, where papillae form, papillae are very geographic, they're very architectural, and they take a while to develop. So where you find papillae is they're always on firm underlines. So on the tarsal conjunctiva, you will get papillae because they have time to really format. But of course, on the bulbar conjunctiva, there's no solid underlay. So when you get an inflammatory response, it's just fluid blowing up and you just get this balloon thing. But make no bones about it, they're the same thing. They're part of the innate immune response reacting. They just, different areas will react in different ways. Now, so that's why it's non-specific. So the innate immune response, the inflammatory response, it simply distinguishes self from non-self. So if something gets in, all it has to do is know that it's not you. So pre-cancer cells, for instance, it'll kill them. Pathogens, foreign body, dead cells, pre-cancer cells, it just recognizes it as non-self and it'll do it. It has no memory. It simply recognizes things that are foreign. It doesn't have to do anything more than that. So as soon as something's recognized as foreign, and of course it's immediate, because the players are in the tissue waiting to go. Like we say, the tissue macrophages, they're ready rock and roll. As soon as something comes in, they just go for it. That's why they're non-specific, that's why they have no memory, and that's why they're immediate. But things can evade it. Or not always evade it, things can actually bulldoze through it. So you've got something that's too virulent, it just bulldozes its way through it. Some things disguise themselves. Some things hide. Like viruses get through this because they go intracellular. It's the same with chlamydia. Chlamydia are intracellular organisms, so they can sort of evade. It's much more difficult to find a foreign pathogen when it's living inside your cell. Some mimic it, and some are just too small. Some, like chemicals, nickel, chlorphenicol, so many other things, they're simply too small to register. And other things are too big. So these things evade the innate system. And that's where we have to move on to the next stage, which is stage 3, which is the acquired immune system. And again, we are taught it's delayed, it takes time. Now, incidentally, it's only delayed the first time. It has memory, and it's very, very specific. So, in fact, back to Von P for a moment, we have now become hypersensitive to that pathogen, right? Or we will become hypersensitive once we're exposed to it the first time. But there is a delay, but only the first time, right? Because it has memory and it's specific, once it's primed, it's ready to roll. So the first time there's always a delay. So that's why you get crook, you get ill, but the second time you respond to it much more quickly. Which is incidentally, if you have a viral conjunctivitis in one eye and it will spread to the other eye may not react quite as badly because by then the acquired immune system has a little bit of time to have kicked in. So with the adaptive immunity, what's the point? Well, again, as I said before, some of them are too virulent, some disguise, some hide. And if the innate immune system doesn't succeed, we need a much more specific thing. And that's where it's triggered. And again, I'll come back to too small because this comes into something I'm going to talk about later. But the hiding one is also important. So there are 3 phases to the acquired response. And the allergic reactions we see are reflections of these normal responses. So we have an antibody response. Okay, we have this middle thing, the cell-mediated one, which I won't really deal with today. And we have a delayed type hypersensitivity. They are all classic parts of the acquired immune system. But with the allergic reactions, they're triggered in different ways. And we will be dealing really with the first one and the third one. So an antibody response. Once we're primed, we produce antibodies. And they're absolutely specific to the pathogen that they've been designed to get, right? And they have to be manufactured post-initial infection. But then once they're produced or once they're triggered, we then produce volumes and they're stored in plasma cells. So that's why the first one we have to specifically get organized to deal with that pathogen. And then later on, though, we store wadges of the stuff so that when the second time comes in, we hit it fast. And so in reinfection, the response is really, really rapid. There are 5 immunoglobulins. And again, we'll deal with 2. IgA is really important. That's in serum. It's in the tears all the time. And I also deal with IgE, which the sole purpose of IgE is allergy. There's no other purpose for this, right? From an evolutionary point of view, we shouldn't really have it. So we argue, why did we get it? Well, in the long and dim and distant past, there was probably a really good reason for it. But now we've evolved on and we don't really need it. I think they're suggesting that it was for big worms and really nasty things. But at the moment now, IgE has no purpose whatsoever. So basically, what happens? Well, we have this one called IgM. Now, we all have IgM in us all the time. It's floating around our blood supply, and it's not specific for anything, right? It doesn't do anything in that sense. But what it does is, just by complete fluke, you might have, if you get a bug coming in, you might have, say, 1 in 100,000 IgMs will coincidentally, by complete chance, have a junction that links on to that pathogen. And that's why there's a delay. So all these other IgMs are going past it, and they don't have the chemical constitution to link to that bug. But then 1 in 100,000 will link on, and that starts a cascade. We talk about clonal expansion and class switch and all sorts of things, right? Which, again, if you're interested, there's good books on it, you can get into it. But what we need to know is that by chance, one IgM will do it, and it's absolutely specific to that bacteria, and that causes the complete cascade, and out comes wadges and wadges and wadges of IgA, say IgA. And that's what works, right? Now that cascade's always happening. Now again, you don't have to know about all the ins and outs of it. You can if you want to, but the point is that's how we get suddenly an absolute masses of one particular immunoglobulin that's utterly specific to that one thing. So if you've got some IgA in your T layer, it'll be utterly specific to the virus or bacteria or whatever that was triggered. But if you have a new virus or bacteria sitting right beside it, it will not do anything because it doesn't recognize that. It's specific for one thing. Now the argument is, why the delay? Why not have it already primed? And basically the argument is the number of different pathogens in the world is vast, and someone added it up. It's representing 10 to the 11 different antibody specificities, right? So to carry that much stuff in our body ready primed, apparently we would need 10 tons of antibody, which obviously is a bit silly. We couldn't walk around like that. So the argument is, since most of us will never encounter the vast majority of bugs, it's stupid to be primed for all of them. And this is why when you get a new bug, so if you go to a new place or a new country, or even a new county, you might hit bugs that you've never been exposed to before, and suddenly you come down with the flu. And this is why pandemics are so dangerous, because we're not primed for them. So if something comes in from over the sea somewhere, suddenly it can rip through a whole population because none of that population's actually been primed. A few will get it, and a few will get through it, and then they'll be ready for the next one. But initially, that's why. So we're bound to see stuff from our local area. We're unlikely to see something from Patagonia. So there's no point being primed for something in Patagonia unless we visit the place. So that's why there's the delay. Now, therefore, then we have lymph glands. Now, these are germinal centers where the pathogen is recognized, right? So the pathogen gets in, it's got through the innate system, it's into our lymph system, and in these lymph glands, they start germinating. They're little mini factories that start producing the goods. But the thing is, the response would be much quicker if we didn't have to go to a lymph gland, right? So if you have to get into the lymph, get to a lymph gland before you start producing a response, that's going to take some level of time. So our bodies are not that dumb. So in areas likely to exposure, the conjunctiva, mucous membranes, the gut, urinary tract, they're all lined with what we call MALT, which is mucosal associated lymphoid tissue. And there's a subset of that on the conjunctiva called COLT, which is conjunctival associated lymphoid tissue. And basically, that's what follicles are. So we're always taught to recognize follicles, only I think most of us can't, right? But the thing is, that's why they look the way they look, right? A papillae has a blood supply up the middle because it's part of the innate immune response, blood supply coming in, opening up. But this is part of the lymph system. That's why they look like little grains of rice. They're clear, they're full of lymph. They're mini factories, they're mini lymph glands producing the stuff that we need. And that's why our gut linings and so on are lined with this stuff. So that's MALT, and we deal with COLT. And MALT equals follicles. All right? Now, many people out there listening to this, if there's anybody listening to this, will not have known that fact. Right? We're not taught that at uni. I don't know why, because it's simple stuff. And once you know that, you can suddenly understand why something looks the way it does. And that's why they're clear appearance and so on. So now we get on to allergy and stuff. So what if everything I've shown you before is normal, right? That wasn't an allergy. That was the inflammatory response. That was our protection. Without it, we'd be dead. But what if it's triggered inappropriately? And that's when we decide to call it, under the Gell-Coombs system rather than Von P, that's when we call it allergy. So we'll go back to this one. We'll deal simply with type 1 and type 4. And type 1 is an antibody response. Right? So it's a Gell-Coombs type 1 IgE So that's the immunoglobulin that's dealing with this. It's an mediated allergy. So back to our IgM again, only this time the trigger, instead of being a bacteria or virus, might be a piece of straw. IgM is floating around. It happens to hit this tiny little bit of pollen or whatever it might be, and it binds to that and suddenly says, oh, okay, we're going to have to produce some stuff here. So they go through exactly the same cascade, clonal selection, clonal expansion, class switch, all that stuff. Only this time out comes IgE. And that IgE is absolutely primed. It's absolutely specific to that particular piece of pollen. And it's ready to go. Now, this, however, is not serum bound. It's tissue bound, or it's cell bound, I should say. And what the IgE does is it binds to mast cells. And then when a pollen comes in and hits that, it degranulates. Right? So it's just the normal response that you saw at the beginning at that graphic that I did, only instead of being triggered properly by, say, a chemical from a tissue macrophage, it's being triggered by this hypersensitive IgE, which is bound to a cell, to a mast cell. So here's a patient for us. He's a 21-year-old male. He drives. His hobbies are football, golf, martial arts. He's a pretty active character, right? He wears Acuvue Moist Dailies +6. He's got asthma. He's on salbutamol for that. He has no preventer, just salbutamol. He's got hay fever. He takes over-the-counter medications. And this came into our practice, an acute presentation, severe itch. Wear time's very poor. He's rubbing his eyes all the time. And it is bilateral, incidentally, right? So what are you going to do with this gentleman? Now, I'll now introduce you to the clinical management guidelines. These are on the college website. They're really, really good. And what do they say? They say type 1 hypersensitivity reaction is to airborne allergens. The mast cells degranulate, as we showed you, and they are caused by seasonal allergens, and there'll be summer and so on and so forth, grasses, early summer and so on. But then there's also perennial. So that's what we talk about, sac and pack. Perennial is dust mites, animal dander, animals and so on. Now make no mistake about this, they're exactly the same process, right? It's a totally arbitrary differentiation. It's just the triggers are different. So we talk about sac because it's seasonal, it's during the summer months, and it's because it's triggered by pollen. But perennial can be any time of the damn year, right? Because it's triggered by dog hair or horses or whatever it could be. And it's any time of the year. But you're going to treat it the same. And it doesn't matter. If someone walks in December and they say, you've got these signs, then it's still the same sort of thing, right? And you're going to treat it. It's exactly the same process. It'll give you itchy eyes, watery eyes, and it's just the season that differentiates it. And they'll say there'll be a bit of edema. Chemosis they talk about, hyperemia, and a diffuse papillary reaction. And the cornea is uninvolved, right? This is really important. So when you're a young optom and you think, oh gosh, what's going on here? If the cornea is uninvolved, you don't have to worry that much, do you? It's just an inflammatory response, really. But often you won't see papillae. Papillae, remember what I said before, they're pretty architectural. They take a while to build up. So with a perennial one, a pack, it's unlikely. It may be quite acute. So you'll get a lot of chemosis though. And remember, chemosis is just billowing out. It's the same process, but it's billowing out over the bulbar conjunctiva. So you may not see papillae at all. You may never see papillae in this sort of stuff. So what do we do about it? Well, try to identify the allergen, of course, advise on avoidance, and then you can start treating it if you want to. And I think this is important. This is not sight-threatening. This is something that we can all deal with quite happily in our own practices. And we've got certain options. Let's bring up what we've got here. The old-fashioned one is a mast cell stabilizer. like Opticron. Now, what you got to remember is what mast cells are great drugs, right? And they're over the counter. You can send if you're not independent prescriber, you can send patients out to get it. But you got to remember, they don't work immediately. If all your mast cells are degranulated in the first place, right? And if I stop your mast cells degranulating now, it could take 10 days for the histamine and so on that's already in your body to come out. So these are really best for seasonal, for SAC, right? So the patient, every April, they say, right, I know I'm going to get it. I start putting this stuff in. And they put it in every day regardless. And that damps down the whole system. But there are these much better drugs now, I think. The classic one is Apatinol or olopatadine. And that's a magnificent drug, right? Because it's a mixture, mast cell stabilizer, antihistamine. So it can be used either chronically over the period, or it can actually be used for acute episodes. So if you know you're going to go out to see a certain friend who's got an animal that you know you're allergic to, you might want to dose up with it. What's also brilliant for this drug is it's only twice a day, which means it's your ideal drug for contact lens wearers. Right? So, and you know, if 40% of the population are atopic, then 40% of your contact lens wearers are atopic. And therefore it makes sense to use it. Right? And you can put it in the morning before you put the lens in, and you put it in the evening after you take your lens out. You can then move on to other things. These are now, incidentally, olopatadine is licensed, right? So you can't prescribe it unless you're an independent prescriber. You can ask your GP to prescribe it. They'll usually will. They'll be quite happy to do it. But then you've got other things that you can do. You've got fluorometholone, which is a soft steroid, and diclofenac and so on, eye drops, which are getting more significant. Now, with this young lad before that we showed you, I used a steroid for him because the symptoms were so severe and he was really uncomfortable. And, you know, I presented this before and people said, I've stopped him wearing his contact lenses. I'm not really sure why. If you've diagnosed it as allergy, it's got nothing to do with the contact lens. Right? It's got to do with the allergy. And he's an active chap. If you're going to tell him to start wearing +6 glasses and start doing his judo, he's not going to be a very happy bunny. So it's perfectly legit to actually treat him, in my opinion, or that's what I did anyway. I treated him with a steroid. And that got rid of the symptoms really fast. It didn't get rid of all the papillae, actually, because he's really bad. He's on chronic use of other things as well. So the steroid was simply get rid of the acute episode. Then we had him onto olopatadine regularly throughout the season. But it worked really well. And he was a happy patient, you know. He's a contact lens where he's come to you for help. Telling him you're going to stop him wearing his contact lens, I just think is just ridiculous, you know. It's not going to make good contact lens patients. So GPC, now this is the thing, we all think, when we see huge papillae loads, we always think GPC, or at least us older people do. You don't see it very much anymore. But papillary, or if too acute, it can be simply chemotic and so on. And it's the same sort of thing, right? It's the same trigger on the body, it's the same inflammatory response, it's just actually triggered slightly differently. So again, you've got this stuff coming in, bang, it does it. But actually, anything else can trigger it. So a contact lens related GPC might not be, I know we're taught there's an allergic reaction to the lens, and it might be allergic to a chemical in the lens, but it could just be the pure mechanics. If you're constantly rubbing, you're going to engender an inflammatory response. And that can do the same thing under the normal system, right? So when you've got a suture, and you flip the lid over, you'll see GPC specifically around the suture. Now, it might be an allergic reaction to something in the suture, but it actually, quite frankly, it could just be the damn things rubbing up and down and causing an inflammatory response anyway, right? Via a mechanical mechanism. And this happens a lot. So it doesn't have to be allergic every time. And again, this is mentioned in the GPC clinical management guideline. It actually says it's multifactorial. It says it can be type 1, an immediate hypersensitivity reaction, but it actually can be a type 4, but it also could be due to trauma. So they're basically saying it's not fully understood. But if we're sieving something, if we're investigating it, and we know it's inflammatory, it doesn't really matter, you know, if you don't actually define the exact reaction. The treatment's going to be the same. It's an inflammatory response. You're going to give them an anti-inflammatory. End of, really. You don't have to start taking them out of lenses like we used to do in the old days. Now they say it's usually bilateral. There'll be papillae, there'll be hyperemia, stringy discharge, and so on. Now, what you've got to understand about clinical management guidelines is they're generic. But again, it hits the trigger. If it's a suture, it's not going to be bilateral, is it? No? It's going to be where the trigger is. So generally speaking, it will be bilateral if it's an allergic type reaction to pollen or whatever. But if it's a trigger based on a trauma to the eye or microtrauma with a suture, then obviously it's going to relate to that thing. So it doesn't have to be bilateral. And again, it's the same sort of thing. Mast cell stabilizer we might give. You can give things like olopatadine again, but you can also give topical steroids if you're keen, right? Or if it's very, very severe. And as I say, it's rarely justified because of the risk of adverse reactions. But, if it's really, really bad, if the patient's in a lot of trouble, the best thing is to remove the trigger. So if the trigger's a suture and you know it can be removed, then if you remove the suture, then the problem goes away anyway. So then we come on to the delayed type. This is delayed type or Gel-Coombs type 4 hypersensitivity. And we do deal with this a little bit. And the classic ones is contact dermatitis, drop allergy, and so on. And in this case, as I banged on about before, the chemicals are actually too small to create an immune response on their own. They're just too small. They won't be recognized. They act as what we call haptens, and they bind to host proteins, and the combo of the host protein and that chemical on them creates a site that the immune system will recognize. Nickel, gold, chromium, chemicals, penicillins, they all produce that sort of stuff. So basically, what happens is you'll have all these little chemicals floating around, and they don't do any harm. They're just floating around. They're just there. But then if you have one that actually hits a self-protein, that's one of us, that's a bit of us, that, and this chemical does it, then these certain cells in the body recognize this and come in, and they start a different sort of system. All right? And what happens is that combo gets carried away to the lymph system, the proper lymph system, not the cult, and they create a cell-mediated system which send out these cells. So this is not IgE now or any immunoglobulin. This is a cell-mediated thing. And they send this stuff out, and they just bring in all the inflammatory responses again, all the cell, the tissue macrophages, all the macrophages, and they just blow up. And that's a type 4 type reaction, right? So it's a different system, and it's producing a different reaction in the eye, which is why you get a different allergic response. All right? So here's a drug allergy, and this is to a drug called Trusopt. And this is a picture from a really good, a really nice ophthalmologist, Bolton Way, I believe, called Chris Heaven. You'll have a slightly red eye, scaly skin, and it's actually limited to the skin. And the drug allergies must be follicular, right, if they're going to be anything at all. And again, there will be no corneal involvement, right? So if someone walks in and you put the fluorescein in, there's no corneal involvement, you're pretty comfortable with this, right? And the hallmark symptom is always itch. Has to be itch. And let's see what the clinical management guidelines say. It's chemical irritation of ocular tissues or a delayed type hypersensitivity. So again, they are specifically saying it's not actually always an allergy, right? We think of it always in that term, but it's not. It could be a simple irritation. And some chemicals, they say, may actually be toxic. So some of the things we're seeing are not always actually allergy, right? And the typical meds, prostaglandin analogues, acyclovir, benzalkonium chloride, and they can do it. And we said, it's an allergic reaction to benzalkonium chloride. Well, half the time it's not, It can produce a diffuse punctate staining of the cornea. it says. You've got chronic epithelial defects, corneal edema, and so on. Now, this is in this thing called conjunctivitis medicamentosa. If it was a pure type 4 allergy, you would not expect staining, right? So this is where we've got to start using our logic. We would not expect staining. If it's toxic, we would, and we're going to talk more about this later, right? So a lot of this stuff, especially benzalkonium chloride, I don't think many people are allergic to benzalkonium chloride personally. It's my personal view. It's toxic. That stuff is toxic. And these people walk in and say, I've got a gritty, irritable eye. They don't talk about an itchy eye because it's toxic. You know, it'll punch through a cell, a bacterial cell membrane, and it'll punch through a human epithelial membrane just as easy. So what we're talking about here is micro trauma. We're not talking about an allergic reaction with benzalkonium chloride. So here's a chemotic inflammation. What is it? Is it type 1? Is it type 4? Is it mechanical? This was a sudden onset, perfectly healthy patient. A nurse, as I recall, had 24 hours of this. Non-contact lens wearer, she just walked in, both eyes blown out like this. No papillae. It's far too acute to show papillae. There's not going to be any. You flip the lids over, smooth as a button, right? But the chemosis is, again, exactly the same process, but on looser tissue. And remember what we say, papillae equals chemosis. Now, I never got to the bottom of this, right? I never figured out what the trigger was. But I knew it was inflammatory, I knew it was acute, and I treated it as such, right? So, sudden onset swelling, lid edema, again, no corneal involvement, and we treat. In this case, as I recall, I treated with diclofenac drops because I didn't want to use a steroid on this lady, and it was all nailed in a couple of days. If I hadn't actually done anything, it would have gone away anyway, right? Because we don't know what the trigger was. It was absolutely acute. It would have gone away again. But, you know, as we say, if you want to look good, you've got to treat it. So I treated it, and it went away. And that's the point I'm getting at here partially. The term drug allergy, drug hypersensitivity, and drug reaction, they're all used interchangeably. And drug reactions encompass all adverse events, regardless of etiology. And this is the thing. 75 to 80% of adverse drug reactions are caused by predictable, non-immunological effects. Irritant dermatitis, epithelial desiccation, drug toxicities. Benzalkonium chloride being the classic one. And what we're talking about there is not allergy at all. We're talking about microtrauma. And it's an interesting stat that 75 to 80% of the things we see are not allergy anyway. We call it allergy, it just rolls off the tongue. Oh, it's an allergy to benzalkonium chloride. Not always, and not usually actually. So here's someone, this was, well, misinterpreted as conjunctivitis medicamentosa, but it's a drug toxicity, and it was interpreted initially as a dry eye, then a drop allergy. And what this lady did was, she came to me as a new patient. She says, I've got dry eye, so I've been putting in visco tears. Right, I was told to put in visco tears. So as soon as you walk in and say, I've got a gritty eye, what do you call it? You call it a dry eye. So someone gave her visco tears. But her eyes were so irritable, and you can see how much staining there is there across the cornea. And if you lift the lids up, it was underneath the lids as well, right? So it's not exposure. If it was exposure-based, you'd lift the lids up and you'd see clear cornea. This was totally pan-corneal. Right? But her eyes were feeling so gritty, she kept putting the stuff in. And when I looked at her initially on the slit lamp, her vision was only about 6'9". And when I looked at her on the slit lamp, I stuck my head around and I said, how often are you putting the visco tears in? She said, well, actually, my eyes have been feeling so dry lately, I've been putting it in 12 to 14 times a day. Is that an allergic reaction? Of course it's not. Right? Now, she had two preservatives. She had preservatives in her glaucoma medication, which is benzalkonium chloride, and in the visco tears, there's something called cetramide. And they're both cationic detergents, right? So her symptoms were blurry vision, gritty. She didn't even report that when she came in because it was so her normal, She didn't even think it was worth commenting on. The only reason I saw it was when I put the slit lamp on, put the fluorescein in, and noted how much staining there was. There was no lid involvement, but it was pancorneal, right? And there was no itch. This was grit. And when you look up benzalkonium chloride and cetramide, they will kill everything, including us, including our own tissue. So this is pure toxicity. And seriously, I had to stop her using this. I put her onto non-preserved drops. And remember what they say, if you put a preserved drop in more than 4 times a day, it's not a possibility that you'll create a toxic reaction. It's absolutely categoric that you'll create a toxic reaction, right? So always, if you're going to use drops a lot, put them on non-preserved. The definition of conjunctivitis medicamentosa, though, is caused by medicines or toxin instilled in the conjunct. There's another synonym is toxigenic conjunctivitis. And this is the point. I think it's toxic rather than allergic. And if there's corneal involvement, you're talking about something else. If it's gritty, you're talking about something else. If it's itchy, then it might be allergic, right? General rules of thumb. And so again, they say on the clinical management guidelines, I'll talk about chemical irritation of ocular tissues or a delayed hypersensitivity reaction, right? They'll say it's either. But if you're using your brains and if you're thinking about it, if it's gritty, irritable, and staining, corneal staining, then you're talking about microtrauma. If it's itchy and it's the lids, then you're talking about a type 4 reaction. And your treatment will then be different, you know. In this patient's case, I didn't give her treatment for an inflammatory response. I took her off the medication she was on. I put her on non-preservatives, and it took some time for it to resolve. So, again, we've gone through those drugs. And Viscotears is just as bad as all the others. It might be cetramide, but it's the same sort of thing. A toxigenic conjunctivitis would certainly cause a diffuse punctate staining. Allergic conjunctivitis. What do we use? These are the sort of things you can use. SAC, PAC, VKC, AKC. I think VKC and AKC you'd probably be referring. Any sort of acute reaction, GPC, and what sort of treatments do we use? Well, you can use your herbal stuff, your eye washes, that gets the toxins out. My drug of choice for mild stuff is always olopatadine now. And even if you have to write to your GP and ask, it builds up a nice rapport with your GP. It's very, very good stuff. And then I'll certainly use FML, weak steroids as well. Eye lube, if it's very, very serious and it produces a lot of mucus. Eye lube is acetylcysteine, which is a mucolytic and so on. But basically, for the mild stuff that you generally see, I think olopatadine or maybe Opticron. But remember, you've got to tell them that you've got to use it chronically for it to really work. Now, I'll put in something here. You can look up these things called summary product characteristics. And for alamide, now I just picked this as one. I could have picked any of them, right? I'm not having a go at alamide, right? But it's an anti-allergenic, and it's a mast cell stabilizer that inhibits the in vivo type 1 immediate hypersensitivity reaction in animals and man. So that's why, again, you need to know these terms. Eye disorders of Zaditan, and this again is in the summary. It causes eye irritation. It can cause eye pain. It can cause punctate keratitis. So these things are all things that we're trying to avoid, and we're sticking in someone's eye. And that's because the chemicals are involved. Right? So an uncommon thing is very bligeon, dry eye, eyelid disorders, conjunctivitis. So remember, these things have preservatives in. They have benzalkonium chloride in. So if it's an allergic reaction, then you might treat it. But remember, they mustn't use it more than 4 times a day. And if you use it more than that, you're going to create more trouble. But again, they're going to come in not with an itchy eye, but with a gritty eye. So back to our questions. What are mast cells for? Well, mast cells are absolutely categorically part of the innate immune response. They're absolutely essential. The only time they involve with allergy is if we're triggering them via an adverse reaction. So our mast cells are essential, and they're going off absolutely all the time. So in a textbook sense, chlorphenicol would be follicular. Right? Now, when I was at college, I was always told everything's allergic, it's got to be papillae. Well, it's not, because this is a type 4 reaction. It's too small to be found, so it creates this other response. And then I would say we are all hypersensitive. We couldn't survive if we weren't hypersensitive. We are hypersensitive to bugs and so on that we've been exposed to previously, and we become hypersensitive to it so that next time we get this particular virus, we can deal with it more appropriately. And this is all non-sight threatening stuff, right? So this is a really good way of introducing yourselves to GPs. You know, if you start asking them for things like, if you're not an IP, ask them for olopatadine, ask them to do this. And, you know, it's a foolish GP that won't respond. That's not sight-threatening. Any of these drugs, in America, olopatadine is over the counter, right? It's a pretty benign drug. So it's a good way to introduce it. And then, you know, if you go along with that and you suddenly start asking for something slightly stronger, like a soft steroid, they're usually going to say, well, okay, I trust this character. I'll go with it and I'll give it, especially if you're writing your letter, and I will review, right? They're happy with that. They don't want the burden. They want it out the way. It's a very good way of building up some level of rapport with your patients. So there we are. I know that took a bit of time, but that's inflammation and allergy. Again, remember, if you understand the first one, you can then understand the second. Thanks very much for listening.